A patient with morbid obesity and chronic obstructive pulmonary disease has presented to the intensive care unit and has been maintained on BiPAP therapy. She is now tiring, having altered mental status, and episodes of oxyhemoglobin desaturation. The intensive care team has now called for endotracheal intubation. The threatened adult airway response team has arrived and has decided to perform a flexible intubation scope aided intubation in her semi-awake state. Local anesthetics have been applied to the airway by holding the patient's tongue and applying 200 milligrams of lidocaine solution via an atomizer. Because the patient rapidly desaturates off of BiPAP therapy, the intubation will take place through an endoscopy mask, which allows the flexible intubation scope to pass through a diaphragm and into the airway. A 5.2 millimeter flexible intubation scope fitted with an endotracheal tube is now passed through the endoscopy mask through the ovosapien airway, which has been placed in the oral cavity and pharynx, and into the larynx and trachea. The tracheal tube is now advanced through the diaphragm of the endoscopy mask and into the airway. The flexible intubation scope has been removed and tracheal intubation verified with the use of an EasyCap2 chemical end-tidal CO2 detector. The diaphragm is now removed. And the endoscopy mask is removed, and the tracheal tube is fixed in position. "24 hours later, the patient is awake and ready for tracheal extubation. The anesthesia team is called to the bedside. After the patient is allowed to breathe 100% oxygen for 5 minutes, a leak test is performed. Now, a 14-gauge Cook airway exchange catheter is placed through the tracheal tube to a depth of 32 centimeters. The tracheal tube is now removed, leaving the airway exchange catheter in place. Immediately, it is noted that the patient has excellent air movement, is awake and alert, and the airway exchange catheter is removed.